Thank you very much. Welcome, everybody. Privileged to be giving one of the keynote discussions this afternoon at this esteemed society meeting about the roles of marijuana, buprenorphine, and low-dose naltrexone for pain management. By way of my background, I'm a professor of clinical surgery and I'm a professor of clinical anesthesia at the University of Illinois College of Medicine here in Chicago, and I work at the Pain Center of Illinois, which is my primary location for where I manage chronic pain conditions. I have no disclosures as it relates to this learning activity, and our objectives today will be very simple. I'd like to describe the role of medical marijuana as an adjunct in chronic pain, primarily to reduce the reliance on opioids, and also to talk about whether or not there's efficacy in the use of medical marijuana. How many folks in the audience are prescribing regularly and routinely some type of medical marijuana or CBD for their patients as adjuncts to chronic pain? So maybe about 15% only, small percentage. What about the potential benefits of the use of buprenorphine? Is anyone using buprenorphine? Mostly transdermal or buccal, or by what route of administration? Mostly. I'll talk to you about the data. The data is really a little bit not what you may think it to be. And at the end of this discussion, I want you to be able to go back to your practices and coherently express why you make certain selections as you would for your patients, and the relative risks, benefits expected by the use of low-dose naltrexone. Anybody using LDN in their practices? So maybe about 30%. Good. So why are we even talking about these three chemicals which are so disparate? They have nothing whatsoever to do one with the other. Marijuana, buprenorphine, and low-dose naltrexone, nothing to do with each other. Basically, it was stimulated by the so-called opioid epidemic, which is the subject of a 5-hour-long discussion. Anybody who has an interest in it, I have a posting on YouTube with my rendition of what I believe to be the etiology and the genesis and the history of the opioid epidemic in this country. I think this is some fascinating information that most clinicians are not really apprised of. So that led to an explosion in ideas and research about how to limit exposure of our patients to opioids, opioid-sparing strategies first and foremost. And in doing so, we came up with old and somewhat even older chemicals. I mean, marijuana's been around for centuries, and buprenorphine's been around for decades, and low-dose naltrexone has been around for decades as well, at least for 25 years. And these disparate chemicals are not related. We discussed that. We know that we can find chemicals that are safer alternatives to opioids. All opioids engender 6 known side effects: nausea, vomiting, itching, urinary retention, constipation, and of course the dreaded bane of our practice, respiratory depression. So we know that we have chemicals that are superior in terms of the side effect profile, and maybe the LD50 ratio, and maybe the therapeutic index. But are these chemicals even viable in terms of managing pain? So I'm not going to talk about CBD, because that's really not the premise of why we're here, which is just one of 140 alkaloids which have been isolated from the marijuana plant. We're talking about marijuana today, first and foremost, and this is the chemical structure of delta-9 tetrahydrocannabinol. So, of course, chronic pain is probably the #1 reason for which medical marijuana is used and prescribed. It's found somewhat effective in nociceptive type pain, cancer-related pain, and neuropathic pain, but not really. And I'm going to show you what the real hard data is that looks at the efficacy of medical marijuana, and primarily THC. We know that the safety profile is superior to opioids. Almost nobody ever dies from marijuana, and certainly not in isolation. But clearly people who are mixing and matching chemicals may have marijuana in their system. In one University of Michigan study, it was found that the use of medical marijuana was attributed to a reduction in opioid consumption by 64%. But what does the data show us about medical marijuana, and what is the appropriate dose of THC for managing pain? How many people in the audience think that the appropriate dose, the effective dose, is 10 milligrams of THC? Show of hands. 5 milligrams. 20 milligrams. Nobody knows. The truth is it's about 20 milligrams of THC. And of course the ideal dosage is one that provides pain relief to the exclusion or the minimization of side effects. So 20 milligrams of THC has been studied extensively in multiple prospective randomized trials and has been found to be the optimal dose for managing pain in this case related to malignancy, but also for neuropathic conditions. But look, if you will, at the side effect profile of 20 milligrams of marijuana. In fact, some authors would stipulate that the benefits of marijuana are due to its cognitive effects, that you don't get analgesia without significant cognitive dysfunction. But if you look at drowsiness, 100% across the board with that dosage. Slurred speech, 80%, blurred vision, 70%, mental clouding, 60%, dizziness, 60%. So the optimal dose of medical marijuana is associated with what some would consider prohibitive side effects. And of course, the generalizability of these results may be limited. Here's another cancer study published in 2018 by Scarborough and Smith, and they found very similar, very small number of high-quality studies. They found only 8 studies in the entire peer-reviewed literature at that time, which were low to moderate quality, and it was not possible to demonstrate a clear therapeutic benefit of using cannabinoids. Again, we're talking about THC here, for therapeutic effects which were limited by adverse effects. How about neuropathic pain? Because some of my colleagues would suggest that medical marijuana is very useful for neuropathic pain, things like CRPS, post-herpetic neuralgia, and so forth. And this was a large Cochrane database review with 94 pages. And I went through, read the entire thing, and summarized it in a couple of paragraphs. The primary outcomes were included that medical marijuana may increase the number of people who achieve a 50% or greater pain relief compared with placebo, but the numbers are not significant. It's 21% versus 17%. So it's almost functioning about the same level as placebo is. And more importantly, the improvement in patient global impression of change with cannabis was very low, 26% versus 21%. So for neuropathic pain, this large Cochrane database review does not seem to indicate that medical marijuana is especially effective. And in fact, in point of fact, the author's conclusions were that the use of medical marijuana may be outweighed, as we've already indicated, the percentages, by the potential harms associated with the cognitive effects, primarily of medical marijuana. How about another article, a more recent one from Italian investigators over in Messina, Italy, looking at the safety of medical cannabis and neuropathic chronic pain management. Again, they found that the drug patients had to get high, or the patients who improved were high up to 80% of the time when they used medical marijuana. And of course, as would be expected, the higher rates of mental cloudiness and cognitive dysfunction were associated when we approached the 20 milligram THC dosage. Cannabis was considered effective for very short-term treatment of neuropathic pain disorders. And interestingly, in all these reviews, none of the studies went out past 3 to 6 months. So people aren't really following medical marijuana for years or decades to really determine whether there's benefit to the use of medical marijuana for the use of either cancer-related pain, nociceptive pain, or neuropathic pain. We just don't know. If there's a benefit, the benefit is exceedingly modest. If the benefit exists, it exists with 20 milligram dosages of THC. If the benefit exists with 20 milligrams of THC, we see prohibitive side effects in about 80% of individuals. And without cognitive changes, the drug does not work. A nice paper that came out of our journal, Pain Physician, by Avram and Samueli Leichtag, showed limited evidence showing pain reduction in chronic pain. 24 randomized control trials were included with more than 1,334 patients. So it's the largest meta-analysis, systematic review ever conducted on the benefits of medical marijuana. Now, the people who advocate for medical marijuana will stipulate to the fact that it is safer than opioids. It's safer than alcohol. It's safer than many of the things we have in our armamentarium for managing chronic pain, nociceptive and neuropathic. There's no significant physical dependence. No reported fatalities from marijuana used exclusively, and not as a polypharmaceutical regimen or a polydrug regimen to manage chronic pain. And compare that to opioids, which of course we know are more dangerous, major side effects, addiction and overdose, naturally and synthetic, with tolerance developing. Medical marijuana, when used with opioids, may lead to opioid sparing. Of that there is no doubt. And there are several studies, both present and in the past, which would indicate that medical marijuana may lead to opioid reduction. And that's probably where it belongs in your clinical pain practice. States with medical marijuana laws have shown reduced opioid-related deaths by some 25%. In terms of physical harmfulness, marijuana is much less dangerous, not just than opiates, but also than amphetamines, barbiturates, and alcohol. We know that. And the estimated lethal dose for humans is 15 to 70 grams per kilogram. So that's the dose that may cause mortality. There's been a 64% average decrease in chronic pain after 1 year of medical cannabis use in a survey, which was not scientific, which was not publishable, of 100 patients. No deaths with solo use. The best safety record of any known pain medication available on the planet. And of course, relief from some things like insomnia, stress, and anxiety, again, attributable to the cognitive effects of the use of cannabis for chronic pain management. It's remarkably devoid of serious side effects. Overdose deaths, again, for the third time, remain largely unknown. Serious allergic reactions are unknown, and there are no absolute medical contraindications to the use of medical marijuana. So the premise for why we should be considering medical marijuana for our patients is not really for analgesia. It's for its opioid-sparing effects and for the interactions at the cannabinoid receptor with the chronic mu receptor, and I'll show you that in just a moment. In some cases, in some countries, especially in British Columbia, for example, they're showing that some patients who are offered medical marijuana before being prescribed opioids never progress to opioid pain prescriptions. So that's another possible benefit of the use of medical marijuana in your patients. Now, there is some interesting interactions between cannabinoid and receptors and opioid receptors. There's an anti-nociception cannabinoid demonstrated potency, which increases or is thought to increase the potency of some, but not all opioids, but does also contribute to the development of hypothermia in patients when you mix and match these chemicals. There's an inhibition of locomotor activity, of course, with people basically feeling very much intoxicated. Hypotension and sedation is additive, but not multiplicative. And the mechanism of opioid-cannabinoid synergy is considered to be at the level of their signal transduction mechanisms, and that also influences what happens when you add medical marijuana to opioids and other chemicals. There's an augmentation or stimulation of the cytochrome P450 system, which can be reflected in the delayed metabolism of certain opioids, for example. And so it's important to consider why medical marijuana. Medical marijuana has usefulness almost exclusively for being an opioid-sparing strategy. The analgesic benefits of medical marijuana alone are very limited and very sparse. It may reduce opioid doses in adults under the age of 40, according to the American Journal of Public Health. Reduction of opioid prescriptions in states has been noted where medical marijuana is legal. That's another benefit for us because we're constantly being scrutinized and monitored by the oversight authorities and the third-party payers and everybody else. And so by being able to reduce prescribing opioid numbers and volumes on a weekly or monthly basis to your patients is an added benefit. So that's really, in 7 minutes or so, the gist of what I wanted to discuss with medical marijuana, and I'll be happy to take questions at a later time after the conclusion of this talk. What about buprenorphine? And I told you that there are many preparations of buprenorphine. There's an intravenous preparation since 1981, which was the first FDA-approved use of buprenorphine. It's a synthetic opioid, derivative of thebaine, antagonist at the kappa receptor and a partial agonist at the mu receptor, 20 to 40 times more potent than morphine. So it's a very potent opioid, even though we don't always consider it as such, and our patients don't report it as such. Well, why don't our patients report it as being a potent opioid? I'll show you that in just one moment. A very high affinity for the mu receptor. It binds tightly. It's excreted very, very slowly and dissociates slowly, and so the withdrawal phenomenon from buprenorphine tends to be substantially milder than almost all other opiates studied. And this is why the patients don't like it, because it's been studied in current drug addicts, opioid addicts, and former recovering addicts, and they don't like it. They don't prefer it over placebo because it doesn't make them high. It doesn't give the cognitive euphoria associated with conventional Schedule II mu agonist opioids. It just doesn't work that way. This was a double-blind, placebo-controlled inpatient study on morphine-maintained abusers that found that they find little drug liking, little drug benefit. They don't select it. In fact, they will push the button for the placebo with the same degree of frequency as they will for parenteral buprenorphine. This was published in 2008. These are the three major preparations which are FDA approved for chronic pain. We're not going to talk about Subutex or Suboxone. Obviously, we know that those are very useful in some patients with chronic pain, but the indications are for opioid dependence first and foremost. The indications for moderate to severe pain are Buprenorphine, which is a drug around since 1981, Butrans patch, been around for 12 years, and Belbuca, which has been around for about 6 years. Those are the only 3 preparations of buprenorphine which are actually indicated for moderate to severe pain. This is the injectable form, and I'll only spend a minute talking about this, and this is the chemical formula of buprenorphine, which I studied extensively going back 20 years actually. So buprenorphine in its injectable form has 324 micrograms per ml. It has water added for injection, hydrochloride added to adjust the pH, and the most important thing here is that it's extremely lipophilic. It's the most lipophilic opioid clinically and commercially available. Buprenorphine is the most lipophilic opioid. Now, why is that important? Well, it obviously has enormous importance for its pharmacodynamic, pharmacokinetic effects. Also, look at the lethal dose in 50% of mice. The lethal dose is 800 milligrams, not micrograms, 800 milligrams per kilogram because of the ceiling effect on respiratory depression. 800 milligrams per kilogram is the lethal dose to kill 50% of mice subjected to buprenorphine. Now, about 10 years or so ago, it was found that buprenorphine, due to its intense lipophilicity and its blockade of sodium channels, works as a local anesthetic. And isn't that interesting? We're pain doctors. We like to add certain things when we do nerve blocks on our patients. We add dexamethasone because the literature shows that steroids may prolong the benefits of local anesthetics. Nothing prolongs the benefits of local anesthetics quite as well as buprenorphine. So why aren't we using it? Well, we don't use it because when we add buprenorphine to local anesthetics, there's about a 50 to 75% incidence of nausea associated with its use, but it's extraordinarily beneficial, much more beneficial than any of the other preparations we have available to us, and it works on the sodium channels almost identical to how lidocaine works. And so, I don't know how to show this, let's see. Here, I don't know. Oh, sorry. Well, we'll skip that. So if you look at the lipophilicity and the potency of these opioids, buprenorphine is the most lipophilic drug, much more so than sufentanil, fentanyl, remifentanil, tramadol, morphine, and the functionality, its local anesthetic blocking properties also mimics that lipophilicity. So it's very useful when added to a local anesthetic. So where do we use it for peripheral nerve blocks? I had the privilege of working with 2 of the founding fathers of the American Society of Regional Anesthesia, Prithvi Raj to my left and Alan P. Winnie to my right. And Winnie was one of the first people to ever consider the use of buprenorphine for prolonging the benefits of local anesthetic nerve blocks. In fact, it does do that. And we studied this for interscalene brachial plexus block. We added buprenorphine to our local anesthetic. We found 17 hours of analgesia versus 5 hours with local alone. Did another study a year later looking at axillary block of brachial plexus. These were all published in high quality peer-reviewed journals, and found again that the duration of analgesia was almost a full day with buprenorphine added to local anesthetic versus only about 6.5 hours without it. So it's an extraordinarily beneficial drug added to local anesthetic. This is our paper that we published along with Dr. Knezovich, who's the president of this society here, and who just left a few moments ago. Published this in the journal Anesthesiology in 2010 for lower extremity blocks, for foot and ankle blocks, and for sciatic nerve blocks for foot and ankle surgery. And we found the same exact thing, that buprenorphine added to your local anesthetic, in this case bupivacaine, provided 36 hours of statistically significant benefit to our patients. Not only was pain reduced, but also their reliance upon opioids in the perioperative period was cut markedly in half when buprenorphine was added to bupivacaine for these patients having foot and ankle surgery. So we know buprenorphine works. We know it has unique properties. It's highly lipophilic. It's highly beneficial. It's more potent than morphine by 20 to 40 times, basically. And we know that it has a prolonged duration of action. We know it has a ceiling effect on respiratory depression. And we know it comes in various formulations, including the parenteral formulation, the transdermal formulation, and the buccal. But does it work for pain? So this is an interesting paper that came from Lynn Webster and Jeff Goodman from New Jersey that found that do you stop buprenorphine in patients who are using it as Subutex or Suboxone? Do you stop it for your patients who come to surgery? How many people in the audience would stop these chemicals if patients came for surgery? Let's say they come in with a fracture and they need orthopedic surgery, or repair, or a replacement. Would you stop Subutex or Suboxone? Anybody? Would you stop? You say yes. Would you stop? Dr. Piriani?
Yes.
You would stop? No?
No.
Dr. Phillip in the back, would you stop? No. And so really, and I'm going to show you, you don't need to stop, but you need to be cognizant of certain things. I'm going to show you that in a moment. This is a nice review of the history of buprenorphine use in this country, going back to when it was isolated in 1966. I already told you in 1981 we had a parenteral form. In 2010 we had the transdermal, and in 2015 we had Belbuca. And this is how buprenorphine actually works. It works on opioid receptor like 1. And so the analgesia is devoid of tweaking that part of the mu receptor which is responsible for respiratory depression. So if you look on the right side of the screen, you'll see there's a ceiling effect, and patients are much less likely. Not that it's impossible, especially if they're using polypharmacy, they're much less likely to die from opioid overdose with buprenorphine. I already showed you in mice, the lethal dose in 50% of the mice population is 800 milligrams per kilogram. So this is the answer to that earlier question. Obviously, the patient who's on no buprenorphine, 100% of the mu receptors are available. Use any opioid you want for your surgery. If they're using 2 milligrams, which is somewhat of a standard dose for Suboxone, 2 milligrams per day of buprenorphine, about 60% of those mu receptors remain available. So you might have to give that patient a little bit more narcotic to get them through their surgery, but you don't have to stop the use of those buprenorphine preparations used for eliminating withdrawal reactions. At 16 milligrams, which is a very high dose, about 20% of those mu receptors remain available. So you still can continue the use of these products into the perioperative period, just increase your dispensation of other opioids to manage their pain. And at 32 milligrams, which I don't know anybody using, still about 16% of the mu receptors remain unblocked. This is a beautiful, nice little review from my friends Mike Fishman and Philip Kim, previously in California, now in Pennsylvania, which details the lack of respiratory effects associated with buprenorphine use. This was a review paper that they published in 2018 in Current Pain and Headache Reports. This is a nice systematic review in anesthesia and analgesia by Amit Gulati from New York and Neil Mehta, who is the chief of the pain program at Cornell University Medical Center. They looked at 25 randomized control trials with 5 different buprenorphine formulations. 14 studies met the inclusion criteria for this systematic review, and they found that transdermal buprenorphine was effective for chronic pain. Only transdermal buprenorphine. So those of you who are using Belbuca, there's no evidence in support or in favor of that. Those of you who are using other preparations, there's no support in the literature in favor, at least as of 2018, for those preparations. Transdermal does have data. And this is why a number of studies with significant clinical benefits where the comparator was a non-placebo, there were 14 total studies, but the studies which found efficacy of transdermal buprenorphine, Butrans patch, were several, and they included a comparator being a placebo. So the evidence is in favor of transdermal buprenorphine, Butrans patch, for managing chronic pain. The evidence does not support it. Doesn't mean it doesn't work, and clinically, obviously, you're left to your own devices and your own judgment, but the evidence does not support the other formulations or preparations. Transdermal preparation of buprenorphine, there were a total of 10 trials, and with the other preparations, there was a paucity of evidence for their use. Doesn't mean you can't use them, doesn't mean you're committing malpractice if you prescribe Belbuca to your patient with chronic neuropathic or nociceptive pain. It just means that if you're asked to substantiate the decision-making exists and is supported by the use of transdermal buprenorphine. So buprenorphine indicated for moderate to severe pain, both in cancer as well as non-cancer pain. And in this country, it comes in several preparations. Butrans does 5, 7.5, 10, 15, and 20 mics per hour. It's a 7-day patch, but you should know that at the end of 7 days, only 15% of that patch is still working. Only 15%. Now, so far in my practice, I use a lot of Butrans. Patients aren't coming back like they do with the fentanyl patch. About 50% of my fentanyl patch patients come back after a 72-hour prescription and say, I need to change this to 48 hours because this does not last up to 3 days. And I do make the adjustment when indicated. The Butrans patch, even though 15% of that patch is effective after 7 days, most of my patients tolerate it all the way out for a full week. In Europe, interestingly enough, the dosages are much higher. In Europe, they're using 3 dosages, 35 mics, 52.5 mics, and 70 mics per hour, but it's only a 3-day patch. And this is the analgesic dose range for buprenorphine and the dose range for drug substitution. This comes out from more than 25 years old data. And finally, the last few things I'll say about buprenorphine. It's a partial mu receptor agonist, so that would tend to decrease the potential for abuse. It's highly lipophilic. It's highly bound to the mu receptor, dissociates very slowly. The withdrawal reaction is very low, slow onset, milder withdrawal symptoms, and is a Schedule III class drug, which is also beneficial to us, those of us who are prescribing, and has much less abuse potential than Schedule I or Schedule II, and moderate or low physical dependence. The final drug I'm going to talk about is low-dose naltrexone. And we've already said that naltrexone has been around for a very long time, as all these chemicals have. It has a variability in its bioavailability up to 5 to 60%, metabolized in the liver by non-CYP450 enzymes. The onset of action is very rapid. The duration of action is greater than 72 hours. And so naltrexone also comes in various preparations and various formulations and various dosing strengths. And so the dose range for standard naltrexone is 50 to 100 milligrams per day, 50 to 100 for opioid withdrawal reaction and to prevent the overdose effects of especially respiratory depression of opiates. The standard dose is 50 to 100 milligrams, and also for opiate abuse and alcohol abuse to prevent cravings. Low dose naltrexone is 1 to 5 milligrams, so it's a fraction of what we use conventional standard naltrexone for. Then there are other types of preparations, including very low dose naltrexone and ultra low dose naltrexone. If you look at the clinical uses of low dose naltrexone, they include disparate conditions like fibromyalgia, multiple sclerosis, Crohn's disease, cancer, Haley-Haley disease, complex regional pain syndrome. Dr. Sloan's written a beautiful paper on low dose naltrexone for the use of complex regional pain syndrome. We'll talk about that. It's been around for a long time, more than 25 years. It started out first when psychiatrists were trying to find a cure for autism. They started to use low dose naltrexone. It didn't work very well, but it worked in some kids with an autistic spectrum. Then in 2005, it was used for multiple sclerosis. Seems to be pretty much effective for multiple sclerosis. And then we first saw it being used in 2006 in Israel for GI motility problems, especially with the use of opioids. This is a paper from Younger, Partickney and McLean, looking at the use of ultra low dose naltrexone as a novel anti-inflammatory treatment. So why would a drug which blocks the opioid receptor have benefit as an analgesic? Well, obviously not in the same strengths, concentrations, and dosages, but in a fraction of that. And it works because it has anti-inflammatory properties. Now, how does it have anti-inflammatory properties? On the microglial cells, essentially. And that has been demonstrated in animals to actually be the effect, at least the postulated effect for the benefits of low-dose naltrexone. It works on the macrophages such as microglia. This is a paper which was looking at fibromyalgia, and you'll see that patients were very much improved, and minimally improved, actually in the vast majority of cases. Another study of low-dose naltrexone and opioid consumption, a drug utilization cohort study that came from the Norwegian group, showed that there was a reduction in conventional opioid use when low-dose naltrexone was added to their medication regimen by 41 drug daily dosage usages. So they basically eliminated about a month and a half of their use of opioids when you calculated how much opioids that they were being prescribed in concomitant or in concordance with the use of low-dose naltrexone. And you'll see here low-dose naltrexone was shown between the initiation of low-dose naltrexone therapy, the reduction of opioid consumption was dramatic, and it was clinically and statistically significant. And the key points and take-home from these investigators was that low-dose naltrexone is followed by a reduction in opioid use in patients who receive low-dose naltrexone more than once. So it's not beneficial to just give them a prescription for low-dose naltrexone one time or 1 month and then walk away. This is something which can be continued for a prolonged period of time if the expectation is opioid reduction. There's a dose-response relationship between increasing low-dose naltrexone exposure and the reduction in total opioid use. The initiation of low-dose naltrexone was followed by a 46% annual reduction in opioid prescriptions for those patients who persisted in the tolerability of low-dose naltrexone. And the reduction of opioid use was not compensated for by an increase in in other medications. They weren't coming back and asking for increased NSAIDs. They weren't coming back and asking for increased gabapentin or Lyrica. They weren't coming back and asking for increases in Cymbalta or other chemicals. They basically were eliminating their requirement for other concomitant analgesics. Here's another paper from my friends Phil Kim and Mike Fishman, again, originally from California, and Phil is now in Pennsylvania. And again, they found that the starting dose, that the range of dosages was about 1 to 5 milligrams per day. Also hypothesizing or postulating or speculating that the mechanism of action is modulating neuroinflammatory processes primarily at the glial cells. And they found that the drug was useful in this review by Fishman and Kim. The drug was used for chronic pain, fibromyalgia, multiple sclerosis, Crohn's disease, osteoarthritis, and back pain with substantial clinical and statistical benefit to patients when it was studied prospectively in randomized fashion. They also found that there's an interesting preparation of oxycodone plus ultra-low dose naltrexone. Now, so you're actually adding a conventional opioid, Schedule II opioid, oxycodone, and to that you're adding ultra-low dose naltrexone, and pain in both males and females with chronic pelvic and abdominal pain was substantially reduced when you added ultra-low dose naltrexone to the oxycodone, and you were also able to prescribe less oxycodone to those patients who had it mixed with ultra-low dose naltrexone. Here's a nice paper again, very recent paper by my dear colleague Dr. Soyan over here with his dear son. You watching my football throws?
He literally was watching it while you were speaking.
Thank you. Thank you. It's all fake, by the way. None of it's real. No, I'm just kidding. It's all real. So Dr. Soyan published the use of low-dose naltrexone for patients with CRPS. Wouldn't we love to find the solution for CRPS? In fact, one of the things that really struck me here was when they indicated in the prelude to their discussion, the National Organization of Rare Diseases has classified CRPS as a rare or orphan disease. And I really had to be taken aback. There's only about 200,000 cases a year of CRPS. Well, I practice in Chicago. About 80% of those cases must happen here in this city. Because there are some places who find CRPS for everything. Stubbed toenails, broken hair strands. Suddenly it's a CRPS issue. And I love that that's what the National Organization of Rare Diseases has done. And I'll be at Azure next week talking about CRPS, and I'm going to borrow that actual graphic from your paper. Thank you. So they found 29 articles, 11 prospective, 10 case studies, 3 systematic reviews, and they looked at the effect of low-dose naltrexone in patients with CRPS on things like sleep behavior, chronic pain, dystonia. They found that there were 5 studies that showed a report of benefit with low-dose naltrexone on fatigue and sleep disturbances. 8 studies found significant benefit for mood, anxiety, and depression. There was at least 1 study that showed that common CRPS symptoms were improved, including CRPS pain, leg and bowel symptoms, and fatigue. And again, the dosages of this paper with Dr. Soyan, when they looked at it, was about the same as what Dr. Fishman and Dr. Kim found. They found between 1 and 5 milligrams. Here they said that the average was about 4.5 milligrams. And of course, you have to speculate or propose or hypothesize the mechanism of action for why low-dose naltrexone works. And the authors stated that in mice, low-dose naltrexone has been shown to block acute thermal hyperalgesia. That may be one of the reasons why it has shown effectiveness in complex regional pain syndrome. Here's another review of therapeutic utilization, low-dose naltrexone. Again, from 1 to 5 milligrams, it's a glial modulator. It works by disrupting the TRIF portion of the signaling cascade, which reduces tumor necrosis alpha and interferon beta synthetase. This all has to do with toll-like receptor 4 functioning. And that's obviously subject for a long discussion, and I won't delay or take up additional time. So my summary and conclusions. The evidence in favor of marijuana use, 20 milligrams of THC, is not very robust, but the side effect profile is fairly profound, may be considered prohibitive. Again, we're not talking CBD, we're talking tetrahydrocannabinol, delta-9 THC. And so it may provide some opioid sparing for some patients under some circumstances. It may lead to a reduction in initiating opioid prescription writing for a certain subset of your patients. There's some evidence that its use has been beneficial both in cancer and neuropathic pain, but the side effect profile is about 80 to 90%. Some authors would claim that you need that mood-altering chemical behavior of marijuana for the effectiveness and the cognitive effect of pain on behavior. Buprenorphine transdermal system only has been shown for promise for chronic pain, appears to be well tolerated, appears to be much safer than conventional opioids, at least in terms of the ceiling on respiratory depression. So that's a major benefit. But remember that your patients who are truly addicted, and that represents 25% of your patient population probably on chronic opioids, those patients don't like buprenorphine. They're going to tell you that it doesn't work for their pain, even though you can educate them and show them graphics that it's 20 to 40 times more potent than morphine. They won't believe you. They don't want it. They want other things. Low-dose naltrexone has an anti-inflammatory effects on glial cells, macrophages, which has been shown to be positive in certain pain conditions. But remember, there's no magic bullet for opioid reduction. Vigilance, monitoring, surveillance of your patients on an ongoing, regular, daily, weekly, monthly basis is the only way to try to safeguard yourself. These are great attempts, heroic attempts, to try to find solutions to America's ever-expanding opioid crisis, with more opioid-related, fentanyl-related overdose in the past 1 year than ever before in the history of this country. Thank you very much for your time and attention. I appreciate that.
I got a quick question for you.
Yes, please.
So going back to the medical marijuana thing, can you talk a little bit about, my understanding is that the marijuana on the market today is genetically modified, including the stuff used for medicinal purposes.
Correct.
And because of that, there's a greater risk of psychosis with use of that genetically modified product. Can you speak on that a little bit, please?
So there's increased risk of psychosis with the genetically modified product, right? That's what the actual. Right, I wouldn't disagree with that. I don't use medical marijuana hardly at all in my entire practice for those very reasons, for the cognitive effects related to the use of it. But there are some patients, there are certain patients who have grave concerns about their opioid consumption, who I have to find something to get them to buy into that isn't a benzodiazepine, for example. Like to get them to buy into the cognitive mood-altering benefits of cannabis, of delta-9 tetrahydrocannabinol. And so, notwithstanding that exactly what you said is true, psychosis can be profoundly identified, especially at the 20 milligram dosages or beyond. I think that if you're more conservative, if you go down to 10 milligrams perhaps of your dosing, then perhaps you'll be able to limit the dysphoria, the dysfunction, the cognitive dysfunction, the psychosis with delta-9 THC, but not eliminate it. That's one of the strategies I've utilized with some success. But again, I tend not to favor the use of medical marijuana for almost any chronic pain condition.
So, are you saying you just prescribe Marinol for them? Is that
So you could prescribe Marinol. Certainly been used in AIDS patients and patients across a long couple of decades now, especially for nausea and vomiting associated with chemotherapy. It's had some efficacy as an analgesic, but not really in peer-reviewed literature. It's been mostly anecdotal, case report studies, and individual reports rather than in peer-reviewed prospective controlled trial. Marinol is a great alternative. And I remember when I was doing my residency and I was in internal medicine a very long time ago, and all these patients with cancer and with AIDS and were being treated with all these highly toxic chemotherapeutic agents. They couldn't stop throwing up, they couldn't consume anything, and you gave them some Marinol and sometimes it worked like magic. And there were some patients by serendipity who also noticed that their pain had improved, but it hasn't been proven in peer-reviewed literature. Yes, please.
I'm no expert in this, but I have heard a lecture by one of our toxicologists in Michigan that there's a subset of dysphoric patients with marijuana actually might be more related to an abnormality on the MOX gene, which is deficient in anywhere between 5 and 13% of human.
Great statistic. I didn't know that at all.
I think tomorrow I'm sorry, I'll get into information, but he presented this about 3 years ago in Michigan, and it's a certain gene that's between 5 to up to 13% of patients or people miss, and that's the rough incidence of severe dysphoria and psychosis with even normal doses of THC.
Thank you for that, and thanks for that education. That's important. Yes, please.
Quick question on the role of benzodiazepines and other sedating agents, negating the respiratory protection and buprenorphine.
Obviously, you can overwhelm any system. If you're going to start dropping Xanax and Klonopin and Ativan and Valium on patients who are consuming any of these chemicals, you can put them into a coma and do worse. So these are clearly, we're talking about single-use indications and not mixing and matching. Polypharmacy is what kills most patients. And that's why it's so important to educate your patients, so important to try to exclude them from being exposed to drugs with synergy. So the synergy between benzos and opioids, of course, is well known to everybody in this audience. And certainly you can overwhelm that potential benefit of Butrans or Buprenorphine or Belbuca by slapping on a couple of Xanax per day. That's not a great idea.
Usually it's the primary care or somebody else keeps prescribing and then.
Well, that's why they ought to be educated as well. Thank you very much. Oh, yes, sir?
A quick comment on the, thank you, spectacular lecture.
Thank you.
Quick comment on the CBD THC. It's my understanding that CBD is a negative allosteric binder.
Correct.
On the THC, and it will have a spectacular reduction in negative cognitive effects. What I generally advise my patients is
Sure.
you'll start low, go slow, and then it's not just a milligram of THC they're playing with, but that's kind of fun about cannabinoid medicine. But as they raise the CBD concentration in the ratio at roughly 1 to 1, where they go higher on the CBD, at any given dose of THC, the cognitive effects will be
Correct, 100%. But as the challenge to me in the title which was presented to me was medical marijuana, and I was very careful because if I went to CBD, I'd be spending another 2 hours just discussing all of those very coherent, very cogent points. So thank you for bringing that to the forefront.
Thank you. Yes, appreciate it. Thank you for that wonderful lecture. You know, Dr. Candido, you're right about my son there watching your football videos. He was watching them as you were talking, and he said, "That's the football guy." And I said, "Yeah, you know, I got 4 boys, and all 4 of them, my 2-year-old, watches Ken's videos, and I have an 8-year-old that has watched every throw and calls him Dude Perfect." And I didn't want to post that on your
Thank you.
thing because that's funny, but now you know.
Thank you.
Yes. So we're going to actually talk about the technology behind localized treatment for